Hello, everyone. Dr. Anthony Capito, and we'll be discussing burns of the hand and upper extremity. I'm part of the section of plastic and hand surgery. Burns are important because over 80% of severe burns will involve the hand and upper extremity. And this is a priority for treatment because this allows for earlier return to work and even more important, ability to care for yourself, feeding, eating, basic activities of daily life. 1% of the population will sustain a significant burn each year. And as I mentioned, the upper extremity is the most common region. And this is for two reasons. A protective reflex, if there's any type of flame or explosion, we commonly use our hands to protect other areas, including our face. And these are typically exposed where there's no protection. Typically people are not wearing gloves all the time to protect their hands. If it's on the dorsum, it's most likely from a flame or explosion mechanism, and the palmar surface is usually a high voltage injury or a specific chemical or friction for a type of rope. The typical burn patient is common and similar to a typical trauma patient, male, Caucasian. Fire and flame are the most common versus a water type of scalding injury. Most occur at the home, and typical patient is uninsured. Go back to medical school. Physiology is important for healing. There is the epidermis and dermis component of the skin, and the papillary dermis is critical for healing of any type of thermal injury, as the midway point between the emergence of the hair and the hair follicle is the bulge. And this allows for regeneration of keratinocytes. So if these are preserved, then the burned areas will heal quickly, typically less than 3 weeks. And if you have a deep burn, these ability to reepithelialize with keratinocytes is lost, and you have epithelialization from the burn edges only. Skin is the largest organ of the body. It provides environmental contact through sensation. Remember, our corpuscles are there for sensation. And also, it's a barrier function. It prevents microbial invasion, prevents evapor loss in the form of sweating, as well as helps with thermal regulation. So a lot of important functions for intact skin. It's our first line of defense against any type of bacteria. This is important for the residents as well as attendings to know where we are not capable of taking care of some of these type of injuries. And referral to the burn center, which in the state of Virginia is Richmond. There's also one in Wake Forest, North Carolina, which is nearby. So this is for any second or third degree burn, not for superficial first degree burn. And we'll discuss how to distinguish between the two a little bit later. There's a little bit of a lower threshold for patients, pediatrics under 10 and adults over to 50, 10% total body surface area. If it is 20%, doesn't matter age. If it's third degree or full thickness, greater than 5%, or if it's in a cosmetically sensitive area as the face or a functional area as the hands or the genitalia, then any type of second or third degree can be referred to a burn center. High voltage injuries also, and then any type of inhalation injury or a patient with severe comorbidities in which the mortality risk will increase, it will be a consideration for transfer to a burn center. Always with any type of trauma as well as burns, remember your ABCs: airway, breathing, and circulation. You want to make sure that there's no signs of inhalational injury, soot in the mouth. And make sure you have adequate IV access because fluid resuscitation is extremely critical for care of these patients. So the ABCs, fluid, and they'll probably be taken care of our emergency room physicians as well as our trauma team. Where we come in for evaluation is burn cleansing. This is essential to assess the depth of the burn. We want to wash these areas with soap and water or remove any blisters. You can't tell how deep the burn injury is with blisters in place or any type of eschar. And we want to calculate the total body surface area involved because this is critical for fluid resuscitation in the first 24 hours. And remember with the rule of 9, superficial burns, basically sunburn, is not calculated into this. There is the adult on the left and infant on the right. The infants give it to the head where it's a full 18, where it's half an adult in most patients, 9%. And they take less off the leg, 13.5 versus 9 on the front on the lower extremity and 9 on the back. The upper extremities are half the size, so it's 4.5 on the front, 5 on the back, or 9% circumferential. So this is a way to calculate the total body surface area. You can also use the patient's hand if it's smaller. That represents 1% of their body surface area, so you can use their palm size to calculate it quickly for smaller burns. That's critical because fluid resuscitation will either be from the Parkland formula, which you should have memorized, or a variant dependent on your institution. And you want to monitor your output. That is the gold standard. So Foley catheterization is essential, immediate for these larger burns, because shock occurs in 15% of total body surface area for the pediatric and geriatric patients, and typically closer to 20 for a healthy adult. You want to get the volume over the half of it over the first 8 hours. I'll say that again, half of it over the first 8 hours, and the second half over 16. And this is from the time of injury, not when they presented to the ED or whenever you first saw them. This is from the time of injury. So resuscitation is critical for the first 24 hours. You also want to consider nutritional support. Feeding the gut is definitely preferable over IV. This is the formula that calculated. This is due to a hypermetabolic and catabolic state in these burn injuries. It can exceed 120%, and malnutrition can malnutrition can lead to wound healing issues, organ failure, as well as susceptibility to infection. So nutrition and fluid resuscitation, very critical to start right away. Early Dopphoff placement, key, feed the gut. So our job is to determine the TBSA, determine fluid resuscitation, as well as the depth of the burn. This is a necessity to dictate further treatment, whether we need surgery or these can heal with local wound care, as well as the location of the burn. Specifically, they involve any joint surfaces where we want to get these areas debrided and reconstructed first to limit the chance of secondary contracture. Dr. Jackson classified and has 3 zones of burn injury. This is important to know and to think about. The central area where there was immediate contact with the thermal energy is the zone of coagulation. This area is necrotic and should be debrided. Immediately outside the zone of coagulation, and 2 on the lower right diagram, is the zone of stasis. This is where there is some vasoconstriction and ischemia. This tissue is not dead yet. It's still viable, and we want to convert this to a healthy transition zone and not turn into the zone of coagulation. So proper nutrition, wound care is critical to allow this area and zone to remain viable. And then the zone of hyperemia is immediately adjacent to that area. That's where there's going to be vasodilation to allow these inflammatory mediators and wound healing to occur. So the zone of injury or zone of coagulation depends on the temperature of the source, as well as the duration of exposure. The palm skin is thicker than the dorsum, therefore there's a more protective mechanism, less likely chance of having a deeper injury in the palm compared to the back of the hand. So you should consider all these when evaluating the patient. This is just a clinical photograph representing Jackson's zone. So zone A will be the zone of coagulation, B, the zone of stasis, and C, the zone of hyperemia. And once again, we're trying to limit the zone B turning into zone A, which require debridement and skin grafting. To determine the depth is critical for our treatment. So a first-degree burn, layman's term, is a superficial burn injury, and it's involving the epidermis only. The basement membrane is intact, therefore you don't need to use antimicrobial ointment for healing. Aloe is just fine. For a second-degree burn, we're going to get into the dermis or the papillary dermis, the superficial part of the dermis. Remember, the bulge of the hair shaft is still intact, so we're able to support epithelialization from keratinocytes. Therefore, these should heal within and less than 3 weeks. Therefore, do not typically require surgery. Whereas if you have a deeper second-degree burn or a deep partial thickness burn, that's the terminology you want to relay to your faculty member, that is involving the reticular dermis or the hair follicle has less chance of re-epithelialization, and there's no source of keratinocytes from these deeper structures. Therefore, re-epithelialization is required from the wound edges. So the larger the burn, the longer it takes to re-epithelialize, the higher the risk of hypertrophic scarring and poor outcome. And then third degree is into the fat that's full thickness, all layers of the skin. So here's some clinical photographs of these type of burns. So a sunburn is a first degree. This is epidermis only. They are erythematous and painful. They blanch. There's no blisters. That's the key here. No blistering. Heals within 3 to 5 days. Use aloe. No need for any topical antibiotic ointment. And there's typically no scarring with these type of superficial injuries. As you get deeper, you will start seeing blistering. So you must remove this blister. You cannot tell if this is a superficial partial or deep partial thickness burn with this blister in place. I expect you to debride them and assess the burns. It's the only way we can determine whether a burn will require surgery or can heal with local wound care. These will remain painful if it's superficial partial, because not only are you retaining the hair and sweat, you're also preserving the sensory end organs, the corpuscles. So these will still maintain the end sensory organs and cause pain with palpation. So if they're painful, they blanch. These are superficial partial, and they should heal within 3 weeks. These do not require surgery. These require good wound care as well as splinting to the limb. But there could still be possible hyperpigmentation, and we'll discuss that later how to prevent that. So moving deeper, now you're into the reticular dermis. This is loss of those hair follicles and appendages. No chance of reepithelialization from the deep structures requires from the edges. Therefore, these require excision and grafting because the healing time will be greater than 3 weeks. High risk of hypertrophic scarring and outcome with wound care alone. These require debridement and skin grafting to replace like with like. You can still see blistering, but the difference here, and you can see how it is less moist, is that it's dry and there's no blanching, and these areas will be insensate. So any non-blanching insensate areas are deeper burns, and those require surgical management. Third degree, pretty easy to tell. These are charred. They're an eschar. They can be hard. They're wet or yellow. There's no blanching. There's no sensation, and they have a more leathery consistency. These are the ones that you have to see and assess which are full thickness, because if they're circumferential, they could lead to a compartment syndrome. Think of a tight cast on a patient. This leathery eschar won't allow for expansion, especially for all the edema and fluid resuscitation. It can cause decreased blood flow to the distal limb in these cases. So our treatment goals is to achieve early wound closure, either by local wound care or surgery with debridement and grafting. This should be completed within 3 weeks to limit the chance of hypertrophic scarring. We want to maintain both active and passive range of motion during this time of healing, as well as in the recovery phase, prevent infection or loss of any skin grafts if performed, and to initiate early functional rehab of these patients to get them back to work, back to living their own lives. So here's the order is evaluation of the size and depth of the burn. If you have a third-degree burn, you need to see if it's circumferential, if there's an eschar indicated. These are emergent type of procedures done in the trauma bay with Bovie. Then you want to initiate proper wound care and dressings if it's a second or worse degree burn. Initiate hand splinting the first day because of the fluid shifts. Surgical management for the deeper burns, and early OT and functional rehab for these patients to get them back functioning in society. We talked about the significant edema shifts within the first 24 hours. This is related to the burn size as well as the total body surface area. This is due to direct heating and injury to the vessels causing permeability, as well as the effects of histamine from the burn mechanism itself, which leads to vasodilation and loss of fluid into the third space. With that significant swelling or with the third degree circumferential burns, you have to have in your mind a possibility of a compartment syndrome. Remember the 6 Ps, tense compartments. You can measure compartment pressures if the patient's obtunded or intubated. And this is where you may need an escharotomy if it's related to the burn eschar itself, or a fasciotomy, and these are typical in high voltage electrical burns because the pathway of least resistance is along the bone and skeletal structures, which leads to swelling in the muscle compartment, requiring a fasciotomy in addition to the escharotomy if there's any overlying deep burn. So an escharotomy is indicated for a circumferential deep burn, third degree. A superficial partial thickness burn, even if it's circumferential, will not cause a compartment syndrome. That is very important for you to think about. And when you talk to anyone that is consulting you for a possible escharotomy, superficial burns do not cause a compartment syndrome. They need that dead eschar that's leathery, that does not expand. Those are the type of thickness burns and need to be circumferential. If they're not circumferential, then that skin that's normal can expand and optimize perfusion to the distal limb. So if it's circumferential, it's deep, better off proceeding just like if you have a clinical suspicion of compartment syndrome, you go ahead and do the escharotomy. And you want to extend this through the eschar, not the fascia. You'll hear a pop. This is done with Bovie. This is blood loss, and it can be done at the patient's bedside. The escharotomy incisions are typically mid-axial. You can see that on the digit itself, or on the radial or on the surface of the forearm. And this should be through the burn-charged skin through the entire eschar. You don't want to cut halfway through the eschar. You want to release it full. That'll allow that skin to expand, almost like splitting a cast that's put on too tight on the patient. You want to split that cast padding. You want to do it the entire length of the limb in order to allow things to open up and for that pressure to dissipate. And you can see a full body type of incisions for the escharotomy, which is different than the fasciotomy. So once again, these are clinical photographs. Here you can see mid-axial in nature. This one anterior to protect the ulnar nerve. You can see how just by placing the Bovie on cuts, this area will pop open if you do adequate release. This also limits bleeding at the bedside. This was required for a chest escharotomy to allow expansion of the rib cage for ventilation. And you can see where they went all the way through the eschar to the junction of normal tissue, and you can see how much this popped open to allow expansion. Briefly, we'll talk about electrical injuries. These are typically high voltage, greater than 1,000 watts. You want to find the contact points because these will have areas of burn from cutaneous injury. They should usually typically have an eschar and consider sulfamylon as the antimicrobial of choice because of its penetration. It's common to have cardiac arrhythmias from electrical injury, and these are very common within the first 24 hours. So they require EKG as well as telemetry if they stay at our facility. You want to protect the kidneys from myoglobin, alkalinize the urine, or not the urine, alkalinize your fluid with bicarbonate to alkalinize the urine and maintain high urine output, similar to fluid resuscitation for a large burn. And because of the injury, there could be a compartment syndrome. So if there's any suspicion, it requires release with a fasciotomy, not escharotomy, but fasciotomy for these injuries. I love this schematic on the top left, figure A, because this is a proper fasciotomy incision. You're going to release the carpal tunnel and then come way ulnar. The reason why you come way ulnar is where you will have tendon and nerve exposure if you go straight or not leave this large radially based flap. Typically, once I do my fasciotomy, I close this area over the tendons and nerve to prevent desiccation, or you can leave this area in the more proximal forearm open, and this is where the muscle bellies are, and this is an area that can be easily grafted, as opposed to the tendons and nerve exposure may require a free flap for reconstruction. So you can simplify your life doing these incisions and placing them properly. So go way ulnar, create a large radially flap. This will allow coverage of the nerve and tendons after your fasciotomy. And then don't forget the dorsal compartment. You can do this with a midline incision as well as release the compartments of the hand. So infection is a big player in burn type of injury. Prior to topicals over 35 years ago, many patients died from burn wound sepsis. This is for topical antibiotics. There is no role for systemic antibiotics. Please do not prescribe Keflex. That is inappropriate, leads to bacterial resistance, and is no shape or form helpful in preventing wound sepsis. They should be in a single bed reverse isolation that help decrease gram-negative sepsis. This was reported in the early 90s. Once you have these hospital-acquired bacteria, enterococcus, or yeast, these can be very difficult to eradicate, so prevention is the best treatment. And infection is still the leading cause of death in burn patients, with pneumonia the number one cause, and burn sepsis relatively rare due to initiation of antimicrobial ointments, as well as early debridement and skin grafting, which is now the standard of care. So for wound care, we want to provide temporary skin cover. We lost our first line of defense with the burn injury. This protects against infection, as well as helps maintain thermoregulation and limits fluid loss. You only need aloe for the superficial first-degree burns because there's still a basement membrane present to allow for that barrier protection. You don't need the antimicrobial component. But for anything that is second or third degree, you definitely need to add an agent to this to help limit a burn wound sepsis. And performing daily wound care allows you to serially examine the wound, as well as helps to debride any non-viable tissue that may occur where you're converting that zone of stasis into a zone of coagulation. Hopefully that's not the case with proper wound care. I place this on the next slide. Once again, prophylactic oral or IV systemic antibiotics are not indicated for burn injury unless there's a documented infection. It does not protect against colonization of the eschar. As this tissue is dead, there's no microcirculation, so there's no way for the antibiotics to get to the area that you need. Earlier colonization is going to be with your gram-positives, and later on with gram-negatives. Pseudomonas is very common with delayed or inadequate treatment of the burn eschar. We'll go through a couple of these agents. Bacitracin is very nice. It's easy. It's cheap. It's painless. Provides moisture in the petroleum base. The downside is limited spectrum. Gram-positive cocci only. Does not penetrate eschars. You need to have this debrided. This is very good for superficial burns that you think are going to heal within that 2 to 3 week time period. My favorite is a triple antibiotic ointment. It has not only the bacitracin, but also neomycin and polymyxin. This is going to give you a better spectrum for both gram-positive and gram-negatives. It is still clear, painless, easy to wash off. I usually place it on a non-curing dressing. I love Adaptic with triple antibiotic ointments. You can place the ointment within the Adaptic, then on the burned area. This washes off easy, allows for assessment because it's clear, and you can assess whether the burns are healing or if they're non-healing with non-blanching with this type of treatment. So this is definitely my favorite recommendation for burn injuries that I see in the ED or in the office. Moving on to Silvadene. This is probably the most commonly prescribed from most other physicians. It still has poor penetration into eschar, so you need to have that debrided. The reason why I dislike Silvadene as it forms a pseudo eschar to the burn tissue. This can look like a deep partial thickness burn. If you do not have experience with Silvadene, it is very difficult to wash off. It basically sticks to the burn tissue. So you have to be very good to know that this burn does not require surgery, because it's very difficult to see if it transitions from a superficial partial to deep partial with this type of treatment. Therefore, I typically do not like Silvadene when I am evaluating and treating a burn patient. I will occasionally use sulfamylon. This is excellent for gram-positive cartilage. It will penetrate an eschar, so for electrical injury or an ear burn where there's cartilage exposed, it is a great treatment. The downside is it is painful, so that's why it limits its utility. And if it's used for a large area, it can cause a metabolic acidosis. For small areas, a palm eschar from a entry wound from electrical injury or exposed ear cartilage, this is your treatment of choice. Some additional ones, silver nitrate. We have the silver nitrate sticks in our offices. They are good as they are broad spectrum and they help with pseudomonas. Downside, it will stain the tissue black. Therefore, the burn depth assessment is hindered by using this, and it does not penetrate eschar like the other ones and can cause hyponatremia or methemoglobinemia with prolonged use with this. So there's a very limited role for silver nitrate. Acticoat, we had this at UVA when we treated burns when I was a resident. It is great for pediatric patients. It's silver impregnated to help resist bacterial invasion. This actually adheres to the burn injury. It stays on. You can even have the kids shower with it. It typically stays on for 3 days. There is Acticoat Flex, a newer product they can leave on for 7 days. So you don't have to do daily wound changes, which can be painful for the kids or even adults when you know the wound is a second-degree burn and does not require operative treatment. This is a nice modality to leave the dressings in place and avoid daily wound care. If there's MRSA component, you can add Bactroban to your mix of treatments. And if you suspect a fungal component, you can add nystatin powder to any of these other ones for a broader spectrum of treatment. So secondary healing with these antimicrobial and the non-stick dressings, these allow reepithelialization, as we talked about, from the hair shaft bulge. This is halfway between the surface of the follicle and the root, and this is within the papillary dermis. This allows reepithelialization from the deep surface as well as from the wound edges and allows the area to heal within 10 to 14 days. So any area where there is more hair, there's a quicker healing time for the donor site or burn injury. If you have a deeper burn thermal injury into the reticular dermis or into the subcutaneous fat, you lose these hair follicles. You only get reepithelialization from the wound edges. So if it's a very narrow area, it can probably heal in a good time frame. But if it's wide, you only get healing from the wound edges. This usually takes longer than 3 weeks, which leads to burn, scar, hypertrophy, and contracture. We get consulted for a hand burn. We just went through a splinting workshop with my residents. It's imperative for you to splint that first day after you remove the blisters, perform the wound care with the adaptic and triple antibiotic ointment, put them in a splint. Should be from the first day of injury because there's going to be significant fluid changes, edema. We want to put them in a safe position of the hand, which I'll remind you is 70 degrees or more flexion at the MCPs. IPs fully extended. And what we want to avoid is the intrinsic minus posture of the hand that happens with hand swelling edema. This happens with wrist flexion, MP extension from the swelling of the dorsal skin, and IP flexion. There can also be thumb adduction, and basically this leads to a claw deformity. This is the worst position of the hand. Therefore, any hand burn needs to be splinted in the appropriate safe position. Jumping into more of the fun stuff, us as surgeons, what is our role? So prior to the 70s, it was very common to leave the burn eschar in place. This promoted proteolysis in an underlying granulation bed to allow for future grafting. The problem with leaving this eschar in place is a lot of prolonged inflammation as the body is trying to heal this, as well as all that dead tissue allowed the bacteria to replicate and become colonized, which led to burn sepsis and death. This female surgeon from Slovenia, Janskovic, reported earlier incidents of problems with burn wound sepsis and death with excision and grafting within the first 3 days of presentation. This improved patient survival, reduced infection rates, decreased hospital stays, as well as getting these wounds covered earlier, decreased hypertrophic scarring and contracture development. She really revolutionized wound care and management of burn injuries, and this is the standard of care even today. So standard of care is to begin burn eschar excision within 3 days. Within 3 days. This is why we are not a burn center. You have to have access to the OR to do frequent and repeat debridements to get all this dead tissue off of the body to promote healing and to allow for skin grafting early to prevent hypertrophic scarring and a faster recovery. If you miss your ideal timeline delay of 3 weeks, you will have higher risk of graft loss due to bacterial colonization, as well as excessive bleeding from this inflamed granulating bed. You want to excise within 3 days if you determine this is a deep partial or full thickness burn, and return every 2-3 days if possible. These are indicated for, like I mentioned, deep partial and full thickness burns. And you want to limit your trip to the operating room to less than 2 hours. Usually, typically have the patient fully exposed. They get cold very quickly, which can lead to hypothermia, which can lead to coagulopathy, excessive bleeding. You want to limit this to approximately 20% body surface area per trip, because that's roughly it takes for 2 hours. You need to be efficient and have a game plan when treating these patients. Estimated blood loss is 100 cc's per 1 body surface area. So if you're doing 20%, you can expect high blood loss. You need to be quick and efficient during your time in the operating room, and have anesthesia most likely require blood transfusions for a large burn debridement. Different techniques. Tangential excision is by far the most common. This is where you're going to remove sequential layers of that burn eschar down to good punctate bleeding. Hopefully you leave some dermis in place, as this is a better wound bed for skin grafting than subcutaneous fat. It is more vascular. The problem with tangential debridement is there is difficult hemostasis. Once you remove that dead tissue and leave normal tissue, you'll have bleeding. This is usually done with either a hand knife, a wet blade seen in the top photo, or a water-powered source, or the VersaJet, which can be used. It just takes a little bit longer time in my hands. Ways to limit blood loss is to soak Telfa, which is non-stick, with neosynephrine or epinephrine to allow vasoconstriction. You can spray thrombin. You can even use a tourniquet or use tumescent solution for hemostasis. I caution using a tourniquet or tumescent if you don't have experience with burn eschar, because you don't have that feedback of fine punctate bleeding to ensure that your debridement is adequate. The number one reason for graft failure is inadequate debridement, and you need experience to use a tourniquet or tumescent to ensure that you had all the dead tissue excised before you proceed with grafting. The wet blade is to your left. The commonly used instrument. We do have them here at RMH. Some of the other bigger knives, the Watson, Cobbett, and Bradwith, are at centers. You can do some significant damage with these. You actually control the death by your own, by increasing the depth of the wheel. By turning this, you can have thicker for tangential excision. You can remove a large area very quickly, and these are typically used at burn centers. There is a technique called fascial excision. This is where you're going to excise the burn through the skin, as well as take all the subcutaneous fats in the suprafascial plane. This will limit blood loss, as this is an avascular plane. And fascia is a good recipient bed, even though there's no fine punctate bleeding, has a low metabolic demand, and will support skin grafts. The problem with this technique is the contour. Remember, you're going to remove subcutaneous fat, so it's a deeper excision, will lead to contour irregularities as well as a inferior cosmetic result. But it can be helpful for large burns, especially when you're running into a lot of bleeding because of the hemostasis with this technique. So once you perform your debridement, you removed all the burn tissue, you're happy with the fine punctate bleeding. We like to replace like with like in plastic surgery, so skin grafting is the mainstay of reconstruction for these patients. Dermal bed is best if preserved. If the burn injury is deeper, you have to excise that off down to subcutaneous fat or to the fascial plane. And the majority is splitting the skin grafts. These do have greater secondary contracture, so you have to be cautious with the palm of the hand or any concave surface, but perfectly acceptable for the back of the hand, any convex surface, forearms, arms, anywhere where it's not concavity or the palm. Splitting the skin grafts are the treatment of choice. The top one is a unmeshed graft, or you can mesh the skin graft to create these little holes. This allows for expansion. This limits the amount of donor site you need to get the source and allows for coverage of a larger area. Also allows for any fluid to egress through those little holes to help optimize graft take. Full-depth skin grafts can be used mainly for the palm or any concave surface like the AC fossa, the elbow region. These are better cosmesis, but they take long to heal. Higher risk of epidermolysis, as well as the donor sites are limited as you have to close these because you're taking the skin and dermis. They will not heal on their own without suturing techniques. So they are somewhat limited for smaller areas requiring this. This is an option. Your split thickness grafts can be thin, intermediate, or thick. Common is about 12 thousandths of an inch, about the thickness of a 15 blade. You may want to consider a thicker graft if you're covering the hand or neck because they tend to be a little bit more durable, but they have a higher chance of having epidermolysis and a higher chance of not taking due to the thickness. So you have to be mindful of that. The interlateral thigh, in my opinion, is the ideal donor site. There's a lot of hair follicles. These surface fairly quickly. And you'll see people that don't have a lot of hair on their thighs. Those donor sites do take longer because they're healing mainly from the edges, not from the deep structures. But you can basically take skin from anywhere. I've taken it from the calf, the top of the foot. Other common areas are the buttocks, back, abdomen. You may need to use towel clamps to get the surface if you're harvesting from the abdomen. But if you're limited donor sites, you may have to resort to these. Scalp is an area where you can use for facial skin grafting because of the color match, and they usually look better than other areas. We mentioned meshing the grafts, typically in a 1 to 1.5 ratio. You can go up to 4 to 1. The more you mesh, the longer the time the wound needs to heal because it needs to reepithelialize those mesh interstices. Sheet graft is an unmeshed graft. They have a little bit better cosmesis, but there's a higher risk of graft failure because of fluid getting trapped beneath the graft. You may need to roll the fluid out, therefore need to examine these within post-op day 3 or 4 earlier than later, or consider pie crusting, which I don't like to do because I can't guarantee that that area is going to be the site where there's going to be some bleeding or fluid buildup. You may want to consider this in a cosmetically sensitive area, mainly the face. It would be an area for sheet grafting. This is the tool you'll use to harvest your grafts. This is a dermatome. This is a Zimmer, which is gas powered. On the right is the blades to determine the width of your skin graft you're harvesting. They're measured in inches, 1, 2, 3, and 4 inch. The 2 and 3 are the most common and useful for this. Here's the blade there, and these protect this, and you can control the depth with this little gauge on the right. Once you get the skin graft, you can place it through a device called a mesher. This is what puts the holes in the mesh or in the skin graft. And the guard itself will be labeled 1 to 5 or 2 to 1, so pay attention to that when you place this. I typically like to place the epidermis side down, dermal side up, so that you can place this directly onto your wound bed after debridement. Placing your skin grafts, you want to make sure that your dermal side is down onto your wound bed. You can see that these are mesh grafts placed on this debrided wound. You want to ensure you have meticulous hemostasis, and then you can use surgical staples or suturing. One is not better than the other. There's still going to be a similar graft take between the two. I typically like staples because they're faster and it does not change the graft take. Also, you can also use Dermabond for any graft interstices where the two grafts come together to seal this off and prevent spreading if you don't want to staple or suture these areas. Dermabond is a select technique you can use. Here's a case of sheet grafting. So here's your wet blade. This is a tangential debridement to remove that burn eschar, but leave a fine, healthy tissue that's punctate. You can do your skin grafts, but you need to assess these areas early, day 3, day 4, because if you see this purple, this is some blood accumulation beneath the graft. You need to make a pie crust and use a Q-tip to roll this fluid. Otherwise, this increases a barrier between your wound bed and your skin graft and lead to graft loss. So this is important to remove this fluid early to maintain the viability of your skin graft. And this will be a cosmetically better result. as well as the healing is faster because you don't have those meshed areas that require reepithelialization. We mentioned this before about the benefits of full thickness skin graft. There is greater primary contracture but less secondary contracture, so better for areas that are concave, like the palm of the hand. They're more durable, they look better, but they have the downside of longer healing, and there's limited donor sites. Some common donor sites, you can use the forearm. The ulnar forearm is hairless in most patients. The upper arm is a great site. You can use the groin or even these hand creases or crease for harvest of small grafts. The grafts are limited in that they require primary closure, therefore useful for small burns, not large burns. The number one reason why your skin graft fails is inadequate wound debridement. That is definitely the number one reason why these are there. You've still left some burned skin. There's an eschar that's colonized. There's limited blood flow that will not support your skin graft. So adequate debridement is a priority for proper burn care management. Other reasons are seroma or hematoma beneath your graft, more common in sheet grafts. May need to pie crust or evacuate the fluid early post-op day 3. So take your bolster dressings down earlier with sheet grafts. If you got them in that window of 3 weeks, the wounds are more colonized. You can have infection. There could be shear if you don't place the appropriate dressings or splints, or inadequate nutrition can cause late skin graft loss. Once you place your skin grafts and secure them with staples or suturing, it's important to have a bolster. You can use a wound vac as a bolster over top of the skin graft. You do need to apply first a non-adherent layer, either Adaptic, Zeroform, or Mepitel. They do not recommend using Zeroform with a wound vac for whatever reason. I typically want to splint the hand in intrinsic plus position to prevent joint contracture. And I also use rest-on foam quite frequently in areas outside the hand, on the forearm, the trunk. This is a foam that can be a compressive type of dressing. There is a peel and stick layer on the top. I usually cut out a 4x4 gauze and place it on the sticky layer in order to hold staples to secure it in place. But remember, before you put your foam down, you want a piece of non-stick, Adaptic, or Mepitel on your skin graft to prevent it from sticking to it, which may cause it to peel off once you take down your dressing. You want to assess these areas typically post-op day 4 or 5. The longer your wait, you're increasing graft loss with colonization. And I typically do day 3 with sheet grafts or non-mesh grafts. And then you want to start hand therapy once you know that your grafts are adherent, begin epithelialized. You want to get their fingers moving to prevent joint contraction and stiffness. Briefly, I'll mention biologic dressings. These are needed when the large burns, you don't have enough donor sites, or the bed is not prepared. You've done a debridement, you're not quite sure. Would take a skin graft. You can use temporary skin. 2 options are allograft from another person, typically a cadaver, or xenograft from a different species. The problem with the xenograft is it does not revascularize. Therefore, allograft is definitely more common. This will lead to less fluid loss, pain, and pathogen growth. It is a biologic dressing. It will actually take and revascularize for 10 to 14 days before it gets rejected. And once it's rejected, some of the dermal elements that are less antigenic will remain in the wound bed. Therefore, the wound bed is even better after doing this in a staged manner for your autograft required, as these are only temporary. You will eventually reject them without immunosuppressive medications. And we do have this at RMH called TheraSkin. You can ask them to grab it for you. It is a piece of cadaveric human skin. It's a variety of colors. You never know what you're going to get. It is in a package, so you cannot see. It's in the freezer. You do have to allow it to thaw, and you just secure it as you would a autograft. And they come already meshed here at Carillion. Some dermal constructs that are used for burn reconstruction is Integra, an alloderm, or a acellular dermal matrix. Integra is more commonly used. That's what I use. It needs to be a non-infected bed. If there's an infection, do not use Integra. It will get infected and melt away. It provides both an epidermis with the film to prevent fluid loss and protect from bacterial infection, as well as allows a new neodermis to form. It is a porous matrix of bovine cartilage and bovine collagen and shark cartilage that allows fibroblasts and endothelial cells to grow. This creates a neodermis that will support a very thin skin graft approximately 10 to 3 weeks later. You can speed up the process of the neodermis by adding a wound vac. You can get it down to about approximately 10 days. It will not support cultured skin. This is important for a derm or burn center, as the Integra does not have a basement, the membrane needed for the cultured skin. Alloderm is basically just human dermis. It will take, it is a thick construct. It can have different thicknesses. It does not have the epithelial layer. Therefore, you'll need to add an antimicrobial agent to support that. And that's why it's typically not used in my hands. There's no survival benefit. They can reduce the incidence of burn scar contracture, though. This is just a figure showing the dermal regeneration layer, and the Integra has the silicone layer preventing fluid loss and bacterial ingrowth. These are the two products you see. This is the Integra on the left and the Alloderm, which is basically dermis on the right. They are acellular. Your body can incorporate them, and they allow you to have a thicker bed for skin grafting if they don't become infected, and that's a big F. This is a case where I used Integra. There were some exposed metacarpal heads from a turkey declawing industrial machine where the guy lost all of his fingers and thumb. I placed the Integra over the metacarpal heads. This is what you should see 2 to 3 weeks later. It is healthy pink neodermis. This is a very good wound or skin graft. I placed this within a skin graft, and this is him healed using this and avoided the need for a or free tissue transfer for this type of wound. So once you've done your debris mix, your skin grafting, or your appropriate wound care and the burns have healed, you want to get them moving right away. Please refer to physical therapy or occupational therapy if it involves the hands. You may want to consider pressure garments. There is a role for silicone scar gels for hypertrophic scarring. Splinting, if there's any type of contractures, make sure that they are pain adequately controlled and they have proper nutrition. And there could be some body temperature regulations even after the areas are fully healed, which we'll discuss later in this talk. So pressure garments. These are great to reduce the incidence of hypertrophic scarring. If the skin in area is healed with less than 14 days, so a very superficial partial thickness burn, typically not required. If it healed greater than 2 weeks, you do need to reassess the patient to see if they develop any hypertrophic scar, as pressure garments would be beneficial. And anyone that has greater than 21 days, you need to get them referred for pressure garments, as they will develop hypertrophic scarring and poor outcomes. Optimal pressure is around 25. This equals capillary pressure, and this you must wear them the majority of the day. 18 hours or greater. You need to do this for months. Compliance is very low in the summer times, but absolutely necessary if they want to have the best cosmetic outcome possible and limit hypertrophic scarring. There's silicone scar gels. You can buy these on Amazon. There's also silicone tape. These are topical. They do help with hypertrophic scarring. They either increase wound temperature or keep the scars hydrated. It's not a pressure phenomenon, but it is definitely the scar cream of choice for me to have some silicone in it. And that's what I recommend to our patients if they're asking about diminishing scar as well as the thickness of a scar. Scar massage with a silicone-based substance is the best compared to other non-silicone substances. The skin can become chapped and desiccate. This is because the skin grafts don't have sweat glands. So you need to advise your patients on frequent moisturizer replacement. I like the petroleum-based products, Vaseline or Aquaphor. They're very greasy. They help prevent the skin from chapping, which can lead to small superficial breaks and blistering. So keep them very moistened with these type of agents. You need to caution them on hyperpigmentation. This is on areas that heal on their own, as well as skin graft areas. Exposure to sunlight can cause this phenomenon. You want to caution them on limiting their sunlight exposure. Use sunblock or SPF protected clothing. And you want to use an agent 30 or higher. 15 will not do it. You want to use SPF 30 or greater. and this can be a problem for up to 2 years. There can be profound itching from the histamine release during the inflammatory phase of wound healing, as well as after the grafts have healed. Antihistamines are usually not effective. There is some creams that have been shown to be better than oral antihistamines. You can even prescribe topical dapsone gel. So keep that in the back of your mind if your patient has any of these problems. Tell the patients that they may have some thermoregulation issues, meaning that these areas that healed or were grafted, they have less blood flow. They have the inability to vasodilate. Therefore, they cannot perform sweating or conductive heat loss. So they end up picking up sweating in areas that are not burned. This can be limited if there's a large burned area greater than 40%. Less than that, they usually compensate well. But some can't tolerate heat, other cold, but they will have some type of thermoregulation issues even once they're healed. So you can caution them about this and discuss this with them. And they usually are very understanding about the pathophysiology once you explain it to them. Neuropathy is something to be mindful of. It happens about 10%, mainly in higher risk for a large body surface area, as well as prolonged stay in ICU, maybe from body positioning or electrical injury. So we talked about compartment syndrome. If you have suspicion, you need to release with either escharotomy or fasciotomy. Avoid tight dressings. Avoid any type of patient position that places traction on the nerves. And you want to limit tourniquet use or frequent use of tourniquet to prevent nerve compression injury. The last thing that can form, and we'll talk about, is HO or heterotropic calcification. This is when bone forms outside the bony skeleton. Roughly 3% of burns will see this. Once again, in major body surface areas, ones that are going to be transferred to a burn center, this can occur. The most common location is around the elbow, especially under full thickness burns in this location. And you can try the typical treatment modalities, both medical with NSAIDs and bisphosphonates. If it's restricted motion, they're quite large, you can consider the excision. That's all I have. Hopefully you learned something about burn care in general, specifically for the hand and upper extremity. If you have any questions, you can reach me by email or stop me in the hallway. Thank you for your attention, and have a great day.